A very good evening to all. Uh, I thank the CCM department of IMS and Some Hospital and Dr. Sakti for giving me this opportunity to discuss few cases of hematological malignancies, especially in an ICU scenario. The topic given to me is leukemia and lymphoma present in ICU. Let's discuss. So, for introduction, the overall survival in patients with leukemia or lymphoma over the last 5 decades have been improving, and it's currently around more than 90% those who are having a long-term survival. But the treatment of hematological malignancies is always changing, and newer therapies always come up every year, and definitely the targeted therapies, the advanced therapies are associated with a lesser toxicity with a better survival. But no doubt, apart from the chemotherapeutic agents, a supportive treatment and a better critical care setup definitely contributes to a better outcome. However, many a times the diagnosing a case of hematological malignancy may be not only difficult, but the treatment may also be difficult and sometimes becomes challenging also. So let's discuss a few. Coming to the first case, the 35-year-old male came with complaints of generalized weakness, progressive pallor, dyspnea and exertion, all for 2 weeks. And when he presented to the emergency, on examination he was having severe pallor, dyspnea, tachypnea with a respiratory rate of 40 per minute. Oxygen saturation was 75% in room air. The blood pressure was 70/50 mm mercury, and ABC showed lactic acidosis. And at that point of time, he was intubated, put on mechanical ventilation along with other supportive treatment including IV antibiotics. On evaluation, the initial blood investigation showed a hemoglobin of 3.5 gram per deciliter, a total leukocyte count of 600 per cubic millimeter, platelet count of 20,000 per cubic millimeter. At that point of time, a hematology consultation was sent, and it has been advised to do a peripheral smear comment. And it showed presence of some atypical cells. So further bone marrow aspiration and biopsy are advised, and showed presence of 80% blast. And further evaluation by flow cytometry for acute leukemia panel showed a diagnosis of T cell ALL. So as soon as the diagnosis was confirmed, treatment started with steroids apart from other supportive measures along with continuation IV antibiotics. TLS prophylaxis was given with allopurinol. Fluids was advised after hemoglobin increased to more than 5. RDP were transfused, and after 2 days it was possible to extubate him, and later on gradually he completed the induction phase, and currently it's now 2 months post the initial presentation, and after the initial phase he was discharged for a few days and again readmitted now for the consolidation phase. So what do we see here? That a proper diagnosis at proper time not only saves time but saves lives also. So regarding pancytopenia, during which was the initial presentation of this case, there was multiple causes might be, and the common causes are hematological malignancy like acute leukemia, lymphoma, multiple myeloma, even metastatic malignancies, non-hematologic malignancy also can cause pancytopenia by infiltrating the bone marrow. Including in the non-malignant causes, secondary myelofibrosis can also cause pancytopenia. Apart from it, infectious agents like tuberculosis, fungal infection, and many other tropical diseases also cause pancytopenia. Wait. Recording start. Along with it, storage disease also can cause pancytopenia, but these are the common present. Storage disease contribute more in the pediatric population. Apart from the malignancies, bone marrow failure can also be a common cause of pancytopenia during initial presentation. The common thing we see is aplastic anemia. Also following chemotherapy, cytotoxic drugs like also following chemotherapy, patient may develop pancytopenia. And apart from it, autoimmune diseases like SLE, rheumatoid arthritis can also cause pancytopenia. And HLH, that is hemophagocytic lymphohistiocytosis, may be a major cause of cytopenia. Apart from this malignant and infectious causes, nutritional causes also are responsible for the low counts. Commonly known agent is vitamin B12 and folic acid. So as we have discussed, and in many cases portal hypertension can also cause hypersplenism and contribute to pancytopenia. So definitely there are lot of causes are there, but only few cases can be discussed at this point. So acute leukemia and lymphoma can present with anemia to pancytopenia, and peripheral smear examination definitely gives a clue in most of the cases, and timely suspicion and intervention can be life-saving. Coming to the case 2, a 65-year female presented with generalized weakness for 3 weeks, swelling of both the legs, fever, anorexia, weight loss of 5 kgs, decreased respiratory distress for 2 days. On examination, there was presence of moderate pallor, respiratory rate was 34 minutes, blood pressure was normal, oxygen saturation was almost normal, swelling of the both legs were present. The left leg swelling was more than the right, along with there was mild redness and tenderness present in both the lower limbs. Initially he was put on antibiotics, oxygens, IV fluids, and on evaluation, initially it was found to have hemoglobin of 6.5 gram per deciliter, total leukocyte count was 1.5 lakhs, platelet count was 60,000, and X-ray test initially showed was normal. Venous Doppler was done to rule out any DVT, and it also showed presence of DVT in both the lower limbs. D dimer of 5, but due to dyspnea, CT pulmonary angiography was done, but it was essentially normal. A peripheral smear at that point of time was done due to high leukocyte count, and it showed presence of 90% blast with presence of ore rods. So definitely AML was there, and bone marrow aspiration biopsy and flow cytometry was done. AML was diagnosed along with molecular panels suggested. Molecular panel was suggestive of FLT3 ITD mutation, which is a poor prognostic marker. But seeing at the age, many times in acute leukemia, especially in AML, treatment depends upon the age of the patient, the performance status, comorbidities, and many things. So in this scenario, along with the supportive treatment like IV fluid, TLS, tumor lysis syndrome prophylaxis, the therapy was in intention to decrease the disease burden, and the cure was not a primary target in this group of population. But especially in this case, the initial management included IV fluids as a part of tumor lysis syndrome prophylaxis. Usually transfusions, mainly PRBC transfusions, are avoided till the WBC count is high, and it is usually preferred to do transfusion once the WBC count falls below 1 lakh per cubic millimeter. But platelet transfusion should be done because in the presence of high WBC count, chances of hemorrhages are very high, and CNS and pulmonary sites are the major sites of bleeding. In this case, cytoreductive measure was taken before the diagnosis of AML. Hydroxyurea was initially started. After confirming the diagnosis by flow cytometry, azacitidine, a hypomethylating agent especially designed for elderly population, was started, and sorafenib, the agent which targets the FLT3 molecule, was also added. And for the existing thrombosis of the deep veins in both the lower limbs, low molecular weight heparin was started, and it was followed by novel oral anticoagulant rivaroxaban was given to this patient unadulterated. Currently, it is 1 year since the initial presentation, and she is continuing treatment on OPD basis and continuing the azacitidine as of now. So what points here we have to note that acute leukemia can present with hyperleukocytosis that can cause leucostasis and even result in deep vein thrombosis. So to discuss leukocytosis, historically leukocytosis was associated with a high mortality up to 20%, but outcome has markedly improved with proper hydration, judicious use of blood product, that is avoidance of PRBC transfusion until we get a WBC count below 1 lakh, platelet transfusion to reduce the risk of CNS or pulmonary hemorrhage, early institution of the cytoreductive measures in such as steroids in ALL, hydroxyurea in AML, cytarabine in AML, and or institution of proper chemotherapy as soon as possible, and the aggressive treatment of coexistent sepsis or tumor lysis syndrome also to be needed. Leukapheresis is what is leukapheresis? Leukapheresis means removing the white cells by mechanical means, that is with apheresis machine the WBC count can be reduced, and it has been previously used to reduce the WBC count quickly. However, there are many pros and cons regarding the leukapheresis. Definitely it can decrease the WBC burden in a short period of time, but definitely it does not address to the cause of the disease. On the long term, it will not be easy or feasible to repeatedly do the procedure in a patient of acute leukemia who presents with these symptoms. However, it may increase the risk of hypocalcemia, which is therapy related, that is it is due to the citrate used during the procedure. Catheter related thrombosis, that means the femoral line or that the dialysis catheter which is used usually for this procedure increases the chances of thrombosis, because not only the catheter but also the high WBC makes the patient prone to develop incidences of thrombosis, along with the coagulopathy may also complicate the procedure, such as low platelet count can contribute to bleeding at the sites and further platelet reduction during the procedure. So leukapheresis is therefore not generally used in children with ALL, because the benefit is usually not seen in cases of ALL, but in AML definitely it could add to better survival during only the initial phase of treatment if done timely. And regarding the thrombosis, there are a lot of new data coming regarding the cancer associated thrombosis, as if now we know that the only molecule which was recently recommended for cancer associated thrombosis was low molecular weight heparin, but the earlier data were, as per the studies, those were done in comparison to the warfarin, but the newer data shows the use of novel oral anticoagulants like epixaban, rivaroxaban, dalteparin, edoxaban. So these molecules have been recently given in many clinical trials, and accordingly different societies have started recommending these newer oral anticoagulants even in cases of cancer associated thrombosis. So the novel oral anticoagulants or direct oral anticoagulant, that is Novax or Dovax, both are the same things. These can be used in cases of cancer associated thrombosis, but the major complication while using these molecules in cancer is usually seen to be GI bleeding. So it's usually said that in cases of patients with GI malignancies or patients having GI bleeding, low molecular heparin is still preferred, but if these are not the primary sites of malignancy, then in that case apixaban or edoxaban, rivaroxaban are usually preferred as per the NCCN guidelines. The apixaban and rivaroxaban needs to be started with a loading dose, apixaban with 10 mg BD for 7 days followed by 5 mg BD, or rivaroxaban can be given as 15 mg BD for the first 21 days followed by 20 mg daily. But edoxaban loading dose is not usually required, but it has to be superimposed with low molecular heparin for the initial 5 days. And if these are not available, in that case dabigatran may also be given, but still dabigatran should be initially be overlapped with few days of low molecular weight heparin. And usually the dose in the cancer associated thrombosis is 150 mg BD. And while we compare the different societies guidelines, we can see the similar opinion such as the International Society of Thrombosis and Hemostasis also says that novel oral anticoagulant like edoxaban and rivaroxaban and the low molecular weight heparin are the preferred agents, but they do not comment on the duration of the therapy. Similar, the NCCN guidelines also do not comment on the duration of the therapy, but the American Society of Clinical Oncology and International Society for Thrombosis and anticoagulation in cancer tell that the same thing, that in the initial phase, apart from the low molecular heparin, rivaroxaban or apixaban, ridoxaban can be used. But in selective cases, when there is the active cancer is still present, in those cases extended period of anticoagulation can be given. It may be beyond 6 months also. Coming to the third case, a 22-year female presented with fever for 8 days, associated with gum bleeding, generalized weakness, cough with blood in sputum for 3 days, and respiratory distress for 2 days. In emergency, on examination, there was presence of pallor. Oral cavity examination showed presence of wet purpura. There was presence of tachycardia with a pulse rate of 110 ml per minute. Blood pressure was normal. The respiratory rate was 35 per minute with an oxygen saturation of 86% in the room air. But there was no hepatosplenomegaly or no lymphadenopathy on examination. On investigation, hemoglobin was found to be 8.2 gram per deciliter. Total leukocyte count was 1800 per cubic millimeter. Platelet count was 20,000. And the peripheral smear examination, when it was advised, it showed presence of blast, but also an increased population of abnormal promyelocytes with OR rods and Faggot cells were seen. These are the Faggot cells in which there are presence of multiple OR rods. So after that, the coagulation parameter was sent. A PT, APTT both were prolonged, which were being corrected after mixing with normal plasma. And a fibrinogen was low. It was 90 milligram per deciliter. X-ray chest was advised for the dyspnea, and it shows bilateral diffuse non-homogeneous opacities. Query bilateral pneumonia was a suspicion, for which antibiotics were not only escalated, HRCT was simultaneously advised, but the HRCT thorax was suggestive of diffuse pulmonary hemorrhage, and the simultaneously corrective coagulopathy measures were taken, and the PML RARA was sent immediately. That is the promyelocytic leukemia and retinoic acid receptor alpha mutation by RT-PCR was sent from the peripheral blood without any delay. As a part of the treatment, patient was put on NIV. IV antibiotics were started empirically, and ATRA, all trans retinoic acid, is a capsule especially targeted for these APML patients, was started immediately. The usual dose is 45 milligram per meter square per day for adults and 25 milligram per meter square per day for children. Judicious transfusion support were necessary. The PRBC was transfused to keep a hemoglobin level of more than equal to 8. Platelet transfusion was given to keep the platelet count more than equal to 30,000. Fresh frozen plasma and cryoprecipitate were given to keep the fibrinogen level more than 100 to 150 milligram per deciliter. After 5 to 6 days, we got the PML RARA report, and it was found to be positive. As soon as possible, we added ATO, arsenic trioxide, as the patient was a case of intermediate risk APML. These days, chemotherapy, the typical chemotherapy, are not required. It can be addressed with, and nearly more than 90%, more than 95% chance of remission is there even with these two agents, ATRA and ATO. Then gradually she completed the induction phase followed by consolidation. Presently it's 2 years post the initial presentation, and now she is on 3 monthly follow-up. So regarding a brief let us discuss briefly about the management of the acute promyelocytic leukemia. This was taken from the European Leukemia Net, published in 2018, and it shows that once a diagnosis of APL is suspected, the disease should be managed as a medical emergency, and patients should be managed by an experienced multidisciplinary team. And if the WBC count is high initially, it may include the use of chemotherapeutic agents, mainly anthracycline like daunorubicin, idarubicin can be used. A cytoreductive measure should be started as soon as possible if WBC count is more than 10,000. Patients should be treated with atra plus chemotherapy if the WBC count is high, and for patient with low WBC count, chemotherapy is usually not required these days, and the leukophoresis should be avoided due to the risk of precipitating fatal hemorrhage, and prophylactic steroids can be given in the high risk patients, which may reduce the complications of the treatment period. Regarding the management of the coagulopathy, treatment with atra should be started immediately when a diagnosed APL is suspected, and the fibrinogen concentration to be kept above 100 to 150 milligram per deciliter through transfusions of cryoprecipitate or fresh frozen plasma. The platelet count should be kept above more than 30,000 to 50,000, and the INR to be kept below 1.5. Apart from that, routine coagulation test monitoring should be done. Central venous catheterization, it is important to note here that the central venous catheterization, lumbar puncture, other invasive procedures, that is bronchoscopy, should be avoided before and during remission induction therapy due to high risk of hemorrhagic complications. So we do not ever do any central line or PICC line in this patient because there is high chances of thrombosis. And regarding the management of APL syndrome, differential syndrome, I don't want to discuss here. So the main points here to note are acute leukemia, mainly the acute promyelocytic leukemia, can present with bleeding, and it can also present with DIC. When we suspect a coagulopathy in acute leukemia, when we see that a patient's bleeding manifestation is disproportionately more than the thrombocytopenia, that means patients with suppose a patient with platelet count of 50,000 bleeding from all sides, then you suspect a coagulopathy should be present. And thrombocytopenia usually presents with mucosal bleeds, but DIC usually presents with bleeds from different sites, even the cannula site, and many other clinical presentation is more severe usually than only thrombocytopenia. And even pulmonary hemorrhages can be a presentation. We have seen 2 cases of APML presenting with like this symptom. It can mimic pneumonia initially to many people, but proper diagnosis at the proper time can lead to be a life-saving measure. Coming to the case 4, a 55-year female presented with fever for 2 weeks, general weakness, cough with expectorations, respiratory distress for 3 days. On examination, there was pallor, pulse rate was 100 per minute, blood pressure normal, respiratory rate a bit high, 30 per minute, oxygen saturation 88% in the room air. On eval, actually she was initially admitted to an other hospital, and she was attended there, and it was found to be having hemoglobin of 6 gram per deciliter. Total leukocyte count was 3.5 lakh per cubic millimeter, platelet count was 30,000, urea was 140 milligram per deciliter, creatinine was 3.5, potassium was 5.5, calcium 6.5, phosphate was 5 milligram per deciliter, LDH was 580, uric acid was 11.5. HRCT thorax showed bilateral consolidations along with ground glass opacities with bilateral multiple nodular opacities in all the zones. Peripheral smear examination showed blast 90% with presence of ore rods. Flow cytometry was done from the peripheral blood. It was suggestive of AML. As the patient was immediately transferred to our hospital overnight, admitted in ICU, put on NIV, antibiotics, IV antibiotics started as soon as possible. Cytoradiative measure was given with hydroxyurea initially, along with continuation of prophylaxis for TLS, tumor syndrome. Allopurinol was given along with IV fluids. RDP transfusion were given because in cases of high WBC count, chances of pulmonary CNS bleeding is high. Even if the platelet of 30,000, we continued the RDP transfusion, but we avoided the PRBC transfusion at this point of time because more RBC transfusion with this high count only contribute to increased viscosity and more chances of Leucostasis and further lead to more complications. And leukapheresis was planned on the next morning, but on the day 2, just before starting leukapheresis, she developed seizure, altered sensorium, intubated and put on ventilation. A CT scan of brain was done, suggestive of massive intracerebral hemorrhage, and patient succumbed on the second day only. We couldn't do anything more than that. Even on the second day, just before the leukapheresis, we lost the time. The points to note here: acute leukemia can be complicated by hyperleukocytosis, leucostasis, CNS bleed, or pulmonary hemorrhage, Thrombosis syndrome. So what is leucostasis? It can, whenever leucostasis is present, immediate measures to be taken for cytoreduction, proper hydration to be continued, along with continuous TLR prophylaxis. Prophylactic platelet transfusion also important to prevent the major bleeding complications. Regarding the Thrombosis syndrome, what is Thrombosis syndrome? It usually occurs when there is simultaneous destruction of a large number of rapidly dividing tumor cells, which causes the sudden release of intracellular metabolites. This results in acute metabolic disturbance, which may include hyperuricemia, hyperkalemia, hyperphosphatemia, and hypocalcemia. This may be associated with uremia also. So the definition was given by Cairo Bishop, and in 2004 the definition was put, and it included lab parameters and clinical parameters. So at least 2 lab parameters should be there, along with or without a clinical parameter. The lab parameters were uric acid more than 8, potassium more than 6, phosphate more than 4.5, calcium less than 7. So uric acid, potassium, and phosphate usually gets increased, and calcium becomes low. So we can remember it as 4, 5, 6, 7, 8. Phosphate is 4.5, potassium is more than 6, calcium less than 7, uric acid more than 8. And the clinical tumor lysis syndrome, a laboratory tumor lysis syndrome plus one of the following criteria should be there, such as the increased serum creatinine. These things are taken as clinical. I don't know why these are put under this heading, but still this is classical, and still we are continuing to follow this. And the creatinine should be more than 1.5 times of the upper limit of the normal. Even to the presence of cardiac arrhythmia also can be considered as a part of clinical manifestation of tumor lysis syndrome. Seizure and sudden death also may be a manifestation. But not only these absolute values which I discussed were important, but also when we have access to the patient from earlier, a 25% increase from the baseline value can also be taken as diagnostic points. So regarding the TLS, it may be asymptomatic but can also contribute to seizures, cardiac arrhythmia, acute renal failure, or even death. Which patients are at high risk? Those patients with pre-existing renal impairment, patients having a high tumor burden in terms of high WBC count, more than 1 lakh WBC count, a large mediastinal mass, bulky lymph nodes, high uric acid levels, and high LDH can also put the patient to high risk of the tumor lysis syndrome. Even that where type of malignancy also important, such as in Burkitt lymphoma, high grade DLBCL. These are also commonly known to cause tumor lysis syndrome. All patients with acute leukemia should be considered to be at risk of TLS irrespective of the WBC count, and they should receive prophylactic allopurinol, there is a xanthine oxidase inhibitor, along with hyperhydration before and for a few days even after starting the treatment, because before starting the treatment spontaneous tumor lysis can occur, and just after administration of the treatment related tumor lysis can occur. So this hyperhydration should be continued even before and continued to be a few days after the initiation of the chemotherapy. Patients with a WBC count more than 1 lakh should receive prophylactic rasburicase, which is a recombinant uric acid oxidase inhibitor, which can be a crucial thing in these patients with a high WBC count and in those patients with a high risk of TLS. And before giving rasburicase, a GCSP deficiency should be excluded, otherwise it may lead to hemolysis and further add to the complications. Coming to the case 5, a 28-year male presented with low-grade fever for 2 weeks, dry cough, swelling of face, swelling of both the upper limbs, along with respiratory distress for 2 days. On examination, he was having a pallor and no lymphadenopathy was present, no hepatosplenomegaly, but edema of both the upper limbs which were non-pitting were present, facial puffiness was there. On mediastinal percussion, dullness was found, diminished breath sound and dullness were present in the both infra and interscapular areas. XHS showed mediastinal widening along with bilateral pleural effusion. HRCT thorax was done and showed mass in the anterior mediastinum around 8 into 10 centimeter in diameter, and there was presence of mild pericardial effusion along with bilateral pleural effusion. On further evaluation, hemoglobin found to be 9, WC count 8800, platelet 1.8 lakhs, peripheral smear was normal, LDH was high, uric acid was 6, CT guided mediastinal biopsy with immunohistochemistry was suggestive of T lymphoblastic lymphoma. But before the diagnosis, he was put on oxygen, IV antibiotics empirically, we just started steroids just after biopsy. Because we don't have time, patient usually deteriorate rapidly. So after giving supportive antibiotics, if we suspect a case of leukemia or lymphoma, we have to start steroids as soon as possible. Otherwise, we may ultimately land up in intubating the patient, or even we may lose the patient if we delay further. After diagnosis, we continued the steroids and patients received vincristine, daunorubicin, L-asparginase as per the LL protocol. Then he completed the induction phase, consolidation phase, reinduction phase. Following that, PET-CT was in complete metabolic response. He received prophylactic cranial irradiation followed by mediastinal irradiation and followed by maintenance. Now it's more than 1 year of maintenance and patient is doing well. So points to note here are: acute leukemia lymphoma can present with a mediastinal mass. Usually the T cell ALL or T lymphoblastic lymphoma present more with the mediastinal mass than the B cell. It may lead to superior vena cava syndrome. The management of lymphoblastic lymphoma is usually almost similar to acute leukemias, and in cases of emergency and suspicion of acute leukemia lymphoma presenting with this superior vena cava syndrome, steroids should be started as soon as possible. But before starting steroid, taking a biopsy is very important, because and in many cases we try to do the biopsy as soon as possible, because as soon as we take the tissue, we can start the steroids, so that not only it gives symptomatic improvement, but also it acts as a pre-phase of treatment before giving proper chemotherapy. And in these cases, cannulation of the upper limbs need to be avoided. In coming to case 6, a 30-year male presented with fever for 1 month, generalized weakness, anorexia, weight loss. On examination, he has a fever, pallor, few cervical nodes, but no hepatosplenomegaly. On evaluation, hemoglobin found to be 6, WC 3500, platelet 80,000, renal function are normal, liver function showed total and direct bilirubin to be 1.8 and 0.8, SGO to SGPT were 180 and 140, LDH was 450, uric acid weight, blood culture and urine culture showed no growth, malaria, dengue, scrub, salmonella were negative. As a part of the evaluation for PUO, echo was done also, it was normal. Hepatitis B, hepatitis C, HIV were negative. So workup for HLS was done, ferritin was high 4500, triglyceride was 360 mg per deciliter, fibrinogen was 140. And again, bone marrow was done for the suspicion of HLS and pancytopenia. It shows presence of hemophagocytosis. But simultaneously, lymph node biopsy was done from the cervical nodes with immunohistochemistry, and it was diagnosed to be case of lymphoma, particularly ALCL, anaplastic large cell lymphoma, ALK positive, which is usually have a better prognosis. And treatment started with antibiotics initially for the diagnosis, and after getting to be a case of HLH, which started fever and the steroids. Fever then subsided. After confirming the diagnosis as lymphoma, chemotherapy was given. Then they completed the first cycle chemotherapy and was discharged. Currently, the patient has completed the 6 cycles of chemotherapy, following which he achieved a complete remission. But even again, after 6 months, he got a first relapse, received again a first salvage chemotherapy, brentuximab vedotin plus bendamustine. Again, attended a CR, complete remission, second complete remission he achieved, followed by an attempt for autologous stem cell transplant. But unfortunately, the stem cell could not be collected in a proper amount, and she continued the maintenance phase, but ultimately he got a second relapse and on second salvage chemotherapy, now in a target to get the third complete remission. So points here to note that the HLH can be a manifestation or initial presentation of a lymphoma. Any case of PUO with cytopenia should be evaluated for HLH or hematologic malignancy. Most cases of HLH are secondary to other causes, and so this should need to be evaluated for the underlying causes. Apart from the malignancy, infections and autoimmune causes also contribute to HLH. The diagnostic criteria is usually 5 out of 8 clinical or laboratory criteria should be there. First is fever, second is splenomegaly, third is cytopenia, at least of 2 lineages. Among the hemoglobin less than 9, platelet less than 1 lakh, or neutrophil less than 1000, 2 lineages cytopenia should be there. Hypertriglyceridemia or hypofibrinogenemia should be present. Hypertriglyceridemia is taken when the fasting triglyceride is more than 265 milligram per deciliter. Hypofibrinogenemia is taken when the fibrinogen is less than 150 milligram per deciliter. Ferritin by definition should be more than 500, but usually it's more than thousands. Cytoplasmic CD25 should be more than 2400 units per milliliter, along with decreased or absent NK cell activity. But more importantly, which is easy for us is to detect hemophagocytosis either in the bone marrow or in any other lymph node or in a tissue. So coming to the case 7, which is the last case I get for discussion. A 70-year-old male with actually the patient presented only this month, and it was a challenging case. Coming to the case 7, is which a 70-year male presented only in September this year, presented with complaint of cough for 1 week, respiratory distress, difficulty in swallowing. On examination, he was having pallor, ecchymosis over the left upper limb, swelling over the neck region, puffiness of face. The vitals were normal. On evaluation, hemoglobin was 8, WC count was 11,000, platelet was 1,20,000, peripheral smear showed neutrophilic leucocytosis with toxic changes, LFT was normal, urea was 60, creatinine 2.5, LDH 800. Dengue was done with due to the bleeding symptoms and with a history of fever, dengue IgM was positive. But during examination, a neck swelling was seen, and due to the history of the dysphagia also, USGnet was done. It showed the presence of thyroid nodule with a hematoma in the right lobe, near the right lobe of thyroid with the multiple cervical lymph nodes. So a CT scan of neck was done, which showed the similar finding with which showed also the presence of lymph nodes with the maximum size of lymph nodes was 2.5 to 2.5 centimeter, but with a presence of thrombosis of inferior thyroid vein. In the ICU, RALS tube insertion were tried for dysphagia, but it was not only difficult, but it led to bleeding and it was interrupted. The patient subsequently developed a cough with blood in sputum. PT was done, it was 25 seconds with a control of 11 seconds. INR was 2, APT2 was 45 with a control of 25. D-dimer was 6.5, fibrinogen came to be 97. Then we did a DIC score, it was 6 and patient was fit for diagnosis of DIC. After 2 days, patient developed syncope and it was found to be 3.5. He was managed with PRBC transfusion along with platelets, FFP, cryoprecipitate anticoagulation at this point in time could not be given for the thrombosis of the inferior thyroid vein. Thyroid mass FNAC was done after few days. What are the bleeding symptoms improved, but it revealed only clots. Biopsy could not be done. CCT, thorax and abdomen was done, and it was essentially normal. Patient was managed with supportive measures only for a week, but after a week, swelling in the upper limb, he developed swelling of the left upper limb, and the Doppler review showed presence of thrombosis in the left upper limb also. But the PT and APTT are still prolonged. Patient is still having cough with blood in sputum. Though he remained clinically stable, he was discharged on request with a plan for doing a cervical lymph node biopsy after the bleeding symptoms subsides or the PT coagulopathy parameters improves, so that we can do a cervical lymph node biopsy, but also we have planned to do a bone marrow aspiration biopsy and a whole body PET CT only after we get the tissue biopsy. So the diagnosis in this case is still a challenge. We don't know whether all these are complications of the dengue, or we are dealing with some hematological malignancy, or the patient is having multiple cervical lymph node which are large enough and can be amenable to biopsy also. So points here to note are the lymphoma or leukemia can present the DIC, but this DIC may interfere not only with evaluation, mainly the invasive ones, but in this case these are usually cases of consumption coagulopathy. So always there is a chance of ongoing thrombosis with consumption of the clotting factors, which leads to further bleeding. So in these cases, addressing thrombosis is very difficult. The management depends upon the predominant clinical feature. If the presentation is bleeding dominant, we have to address that. If the patient is dominantly thrombotic, we can address to anticoagulation. But simultaneous presence of thrombosis bleeding makes the management challenging, though commonly it is known as DIC is death is coming. So finally, some take-home messages. I may conclude with this slide that in acute leukemia lymphoma, initial presentation may be varied, ranging from incidental detection to life-threatening events. Sometimes the initial presentation may be misleading too. Even the ongoing treatment involves few therapeutic challenges like posterior reversible encephalopathy syndrome, differentiation syndrome in case of acute hemolytic leukemia, thrombosis syndrome, febrile neutropenia, neutropenic sepsis, etc. All possible differential diagnosis should be kept in mind while managing the case of acute leukemia lymphoma. The better clinical care and supportive care, no doubt, they can contribute to a better outcome. So only the cases I discussed are at the tip of icebergs only. There are many other scenarios in emergencies hematology like supravenous syndrome, hyperleukocytosis, acute spinal cord compression, venous thromboembolism, pulmonary embolism, thrombosis syndrome, hyperviscosity, hypercalcemia, sepsis, febrile neutropenia, DIC, autoimmune hemolytic anemia, elimination, HLH, post-chemotherapy, posterior reversible encephalopathy syndrome, febrile neutropenia, CRD, mucositis, and in cases of the BMT, we face few other challenges like engraftment syndrome, vein occlusive disease, thrombotic microangiopathy like TTP, thrombotic thrombocytopenic purpura, GVHD, that is graft versus host disease, and in the upcoming CAR T cell therapy, that is chimeric antigen receptor T cell therapy, we usually face CRS, that is cytokine release syndrome, which is similar to engraftment syndrome due to increased release of cytokines. There are many other issues to be discussed in ventilation in a hematology patient, ECMO in hematology patient, and COVID in but these are beyond the time and scope of this discussion. But I like to highlight these things can be a part of potential discussion. Thank you.